Okay. All right, we are good to start. Apologize for the delay for today, but good morning, everyone. Thank you for joining our race and ethnicity data imputations in Medicare and Medicaid CHIP sessions. As some of you may know, late last year, we released the paper from the CMS Office of Minority Health titled The Path Forward Improving Data to Advance Health Equity Solutions. In general, that paper describes the current state of health equity data collection and the consolidations across CMS programs, details progress to date on our health equity data initiatives, and defines CMS future actions to continue the improvement of health equity. So following on that theme, as well as the continuous conversation we hear yesterday about data, we want to take the opportunity today to showcase to you all some of the initiatives we have taken to improve our existing data while we explore options to improve our data collection. Some of these initiatives are through the use of imputed algorithms, which Dr. Nancy Charles Schaefer will talk about for the Medicare race and ethnicity data. And Dr. Kimberly Proctor will speak about the Medicaid and CHIPS race and ethnicity data as mentioned by our administrator, Brooks LaSure, yesterday. I know you all have the bio, but since some of the work they do are very important to the presentation today, so I'll take the opportunity to introduce them. So Dr. Nancy Charles Schaefer currently serves as a technical director in the CMS Office of Minority Health Data Analytics and Research Group. Previously, she served at the Center for Medicare and Medicaid Innovation as the evaluation lead for the Financial Alignment Initiative model. Nancy was also at the National Institute of Aging at NIH, researching changes in body composition and physical performance with age, health disparity, and minority aging as a fellow. Dr. Kimberly Proctor is the Chief Data Officer for the Data and Systems Group in the Center for Medicaid and CHIP Services, and is responsible for leading the center's analytic vision for Medicaid and CHIP data. With an extensive background in analytics, she has led projects relating to TAMS's analytic files, Medicaid DQ Atlas, geocoding Medicaid and CHIP beneficiary addresses, and examining the impact of COVID-19 public health emergency on Medicaid and CHIP beneficiary. Previously, she led research in the CMS Office of Minority Health relating to quality of administrative data across topics such as race, ethnicity, language, sexual orientation, and gender identity, including work that was published in peer-reviewed journals such as Transgender Health and Health Equity. So with that, I will turn it over to Dr. Charles Schaefer.
Good morning, everyone. As noted, I am Dr. Nancy Charles Schaefer. I am a Black woman that is wearing combinations of navy, white, and tan this morning, and I will be talking to you about the Medicare Bayesian Improved Surname Geocoding. So I will begin with a background on race and ethnicity data in CMS, focusing on Medicare, dealing with the Social Security Administration, obtainment of race data, an overview on imputation thus far, and then we'll go into MBIS-G. So since the inception of the Medicare program, race and ethnicity data has been obtained from the Social Security Administration from Form SS5, which is used when one would obtain a Social Security number, replacement Social Security card, or in instances where personal information would be updated on the card, such as a change in name. This form, and specifically what race and ethnicity options are available for response options on the form, have changed over time. So from 1936 through 1980, there were only 3 race options that one could use for reporting their race, and that was Black, white, and other. And where there was a non-response, this was marked as unknown. So if we think about the Medicare enrollees, particularly those that are eligible due to age, so 65 and older, the bulk of their race and ethnicity data would have been obtained from the Social Security Administration during this time with this very limited set of options. Then from 1980 through 2019, there were 5 options for race and ethnicity: Asian and Asian American or Pacific Islander, Black, Hispanic, Northern American Indian or Alaska Native, and white. And then from 2019 through present, 8 options for race and ethnicity: Alaska Native, American Indian, Asian, Black African American, Hispanic, Native Hawaiian, other Pacific Islander, and white. It's important to note, however, though, that the information that was obtained through 2019 through present largely does not make its way to CMS, as that Form SS5 is now not the primary way by which race and ethnicity are obtained for the Social Security Administration. So while there have been improvements in terms of what categories are available for reporting, the Social Security Administration has been obtaining this data through other means, so that's not currently making its way to CMS. So where does imputation fall into all of this? We know that the gold standard of reporting race and ethnicity is self-report. However, as was just noted, there are instances where obtaining this data through administrative data is limited or imperfect. So in those instances, imputation is a helpful key piece for filling those gaps in data. So if we have missing or poorly measured race and ethnicity data, this can create barriers for monitoring and improving quality, coverage, costs, and access to care. And in these instances, the National Academy of Medicine has recommended indirect estimation as a means for improving efforts for assessing disparities and health equity. Indirect estimation methods can better align administrative data on race and ethnicity with what an enrollee would choose to self-report if they had a wider set of response options. So in addition, we have data that is available that can lend itself to imputation. So name, administrative data, and census data. So classically, the imputation method that has been used and obtained from the Chronic Condition Warehouse is the RTI race code, which was developed by the Research Triangle Institute, RTI. This method uses a combination of variables, including race and ethnicity data from the Social Security Administration, as well as first name and surname and residence in Hawaii or Puerto Rico, in order to improve classification, in particular of Asian and Pacific Islander, as well as Hispanic individuals. So on the screen is a table showing the RTI race code and values. So code 0 for unknown, 1 for white, 2 for Black or African American, 3 for other, 4 Asian or Pacific Islander, 5 Hispanic, and 6 American Indian or Alaska Native. On this screen, it's showing a side-by-side comparison of percentage of enrollees using both the SSA race and the RTI race code. So in particular, we see, thinking about the objectives of the RTI race code largely being improvement in Asian Pacific Islander as well as Hispanic reporting, that there is an increase for Hispanic between the two, so 3.1% with SSA, compared to 9.6% with the RTI race code. And then if we look at Asian or Pacific Islander, there's an increase from 2.6% with the SSA to 3.5% with RTI. Additionally, it's important to note that there's a decrease in reporting of unknown when using the RTI race code. So we go from 2.4% unknown with the SSA race data to 0.9% with the RTI race code. So we're seeing here improvements from imputation. So where does MBISG fall into all of this? The Medicare Bayesian Improved Surname Geocoding, again, MBISG, is a method for further improving upon CMS's administrative race and ethnicity data. It uses the original reported data obtained from SSA and also considers enrollees' neighborhood composition and other information that's available via administrative data in order to provide a better match, again, with what beneficiaries would self-report if they had a fuller set of response options. So the MBISG method is a modification of BISG, the Bayesian Improved Surname and Geocoding method, which uses Bayes' rule to combine census information on race and ethnicity with surname and census block group of residents in order to produce a set of probabilities for several race and ethnicity groups, which are white, Black or African American, Hispanic, Asian or Pacific Islander, American Indian or Alaska Native, and multiracial. So the Medicare specific adaptation, MBISG, takes this BISG method and then utilizes CMS race and ethnicity data and additional administrative data from the chronic condition warehouse in order to create a more accurate indirect estimation of race and ethnicity for Medicare enrollees. So there are predicted probabilities, which are collaborated with correlation with self-reported data. And then additionally, the models are validated using tenfold cross-validation. Here we see side by side some of the differences in the methodology behind MBISG and RTI race code. So looking at the form of the predictors, MBISG has continuous as well as categorical predictors, where RTI is categorical. In terms of how these predictors are combined, again, for MBISG, this is utilizing Bayes' theorem and multinomial logistic regression, whereas for the RTI race code, generally this determines if one's first or last name is of Hispanic or Asian origin in order to classify one as Asian or Pacific Islander, as well as Hispanic, in addition to location of residence. The racial and ethnic categories used for the two methods are largely similar, although multiracial is an additional option with MBISG. And then with missingness, what's important to note is that MBISG is able to provide an imputation probability for 100% of all categories, whereas there are 2% of race and ethnicity categories that cannot be imputed with the RTI race code. On this table, we see comparisons of percentage correspondence of the MBISG probabilities, RTI, and SSA compared to self-report from the Medicare Current Beneficiary Survey. So important to note, specifically some of the aspects that are highlighted on the screen, which are that MBISG improves the percentage correspondence for Asian or Pacific Islander. So that's roughly 88% correspondence with MBISG compared to 68% for RTI and 55% from SSA. For American Indian or Alaskan Native, it's 42% correspondence with MBISG compared to 41% for RTI and SSA. Also important to note, although not highlighted, is that MBISG maintains that improvement in Hispanic correspondence. So we see 82% with MBISG compared to 83% for RTI and 32% with SSA. So there are a couple of aspects that are important to note and keep in mind when considering utilizing MBISG. The first is that this is used primarily to enhance limited self-reported data. There have been some critiques suggesting that this is primarily used to supplement where one chooses not to report. However, this is not largely the case. Again, it's meant to improve self-report in instances where there's not a full set of response options available. When asked to do so on an MCAT survey, more than 95% of all Medicare enrollees reported their race or ethnicity, and largely those that did not report never made it to the end of the survey. So we're seeing largely that people will report their race and ethnicity when allotted a full set of response options. But again, by drawing on additional sources, we're able to supplement in instances where a full set of options are unavailable. Another important aspect to note and highlight is that MBISG should be used to make inferences for groups, not at the individual level. So this generates a set of 6 probabilities that an enrollee would self-identify as each of these race or ethnicity categories. So this probabilities for each of these categories reflects uncertainty associated with each category for each person. So this again is really helpful for drawing inferences about groups. So in instances, for example, iterate, it should not be used at the individual level. There are on the screen some examples of applications of MBISG. So measuring race and ethnicity differences, involuntary disenrollment from Medicare plans, imputing race and ethnicity for survey respondents who did not report race and ethnicity, developing a health equity summary score for Medicare Advantage plans. I will put in a plug for a session later this afternoon on health equity and disparities indices, including the HES. So pay attention to that around 155, I believe. Additionally, CMS OMH produces stratified reports, which utilize MBISG. A recent example is disparities in healthcare and Medicare Advantage by race, ethnicity, and sex. Also characterizing racial and ethnic inequalities and behavioral health quality measures in Medicare health plans. And then lastly, characterizing Medicare beneficiaries in the fiscal year 24 inpatient prospective payment systems proposed rule. In order to obtain user access, there is a support box for MBISG. Currently, this is available for internal CMS users and CMS contractors via the Chronic Conditions Warehouse, the CCW. There will be an additional annual release in the fall to include enrollees through spring of 2023. We also have a roadmap for 2023 to expand access to MBISG to users of the Integrated Data Repository, IDR, as well as general CCW users. We also can provide additional support for MBISG by reaching out to that mailbox, and that support mailbox is MBISG, so MBISG @cms.hhs.gov. Also on the side are the names of the MBISG contacts in the Office of Minority Health at CMS, so myself, as well as Tori Hill, who is our subject matter expert for MBISG. Here are a list of some key publications for MBISG. These are really helpful if you want to get more into the methodology and other use cases for this imputation method. And with that, I thank you and we'll turn it over to Kim Proctor.
Hi, everyone. I'm Kim Proctor. First, thanks so much for that great presentation. So before I start, I just want to give some context for this presentation and why I'm so excited to be here. So I used to work in the Office of Minority Health, and I think it was in 2014, I gave a presentation on imputations in Medicare. And the first question I got from the audience was, okay, what about Medicaid? And at the time, there was not any work happening on imputations in Medicaid, but that question haunted me. So almost 10 years later, I'm here to tell you, we've been working on this for a very long time, and I'm so excited to share this with you today, and also to just say what great work you guys continue to do on evaluating those imputations for Medicare. Okay, so to start, first, I just want to talk a little bit about the program in case some of the people in the audience are a little bit less familiar with Medicaid and CHIP, kind of what the structure of our data is like and some of the things to think about if you use our data or interpret it. And then we'll talk about what our race and ethnicity data looks like, and then how we're working to improve that to make it more analytically useful. And then some very exciting results that we were able to release yesterday. So hopefully a lot of exciting stuff today. So Medicaid and CHIP are federal health coverage programs that are administered individually by states and territories. You can see some of our large eligibility groups that would commonly be referenced in some of our materials: parents and children, pregnant individuals, older consumers, people with disabilities, other low-income adults, kids. We cover a huge group of people, lots of variation across the eligibility categories and just very large size. So just trying to give some context on what does this program do and who is covered by this program. Sorry. Okay. And then just to kind of reiterate that, you can see here from our most recently published performance indicators report, that is over 93 million people. So this is just an enormous program, lots of different types of people, lots of different eligibility categories. You can see here almost half of those enrollees are children. So just plays an enormous role in the lives of children in this country. So just a very, very large program with a lot of different eligibility groups. Sorry, I must be pointing this like at the ceiling. Apologize. Okay, and so what does our data look like? So the primary way to get information about enrollees and their services is via the TMSIS analytic files, which we call the TAF. This way, sorry. Okay, so how do we get the TAF? What does this look like? So states and territories submit their data from their Medicaid Management Information Systems, their MMIS systems, via the TMSIS format to CMS. So what that means is every single state has to package their data into this format and send it to CMS. So we're getting data separately from every state, right? So you can just think about the context that would mean from an analytics standpoint. So we take that data and we ingest it at CMS. That's a relational database with all of these different record segments. And we transform it into a more research-oriented version of that data so that if you're a health services researcher, you're a data analyst, it would be a more easily accessible format for you where we've kind of packaged it in a way that you could actually do analytics. We have a variety of file types. So we have information about enrollment, managed care plans, providers, and claims. There are 4 claims types. So basically end to end, you can learn about an enrollee's eligibility, the claims that they're receiving, who's giving it to them, and what the plans are like that are operating. Okay, but we just heard about how the data was submitted from all different states and territories, right? So data quality becomes a significant issue with Medicaid data. And that is because there's a lot of variation in terms of what states actually submit. So there's kind of 2 types of variation to think about when you think about Medicaid. One is variation in state program design. So every state is different, right? Every single state is different. And then in addition to that, the quality of the data that states are submitting is different. And then within that, the quality might vary by file type, eligibility group, plan. So there's just a lot of natural variation to the data, variation from the program, variation from the quality, even within a state, variation across the elements. So we have this great tool that we've been working on for a number of years called the Medicaid DQ Atlas. It's a tool you can go to help contextualize the variation. So for a lot of key topics, you can understand, is this probably high quality? Should I maybe be a little bit concerned? Should I be seriously concerned? So it gives you a range of, I would say it helps give you a range of how to estimate the uncertainty of what you're looking at. Is it most likely to be highly accurate, or might I want to do some additional investigation? We have a variety of topics. We continue to add topics to DQ Atlas every year. So if there's not a topic, if you're interested in something specific and it's not there, there's always the chance that it will be there in the future. I have a help desk reference at the end of this presentation. If there's a topic you want to see, please email the help desk. We keep a log of all of this and we try to prioritize the things that we consistently get questions about. There are also some great resources like our data dictionaries. There are some methods documents. So there are also materials that are in Atlas, not on the national maps and things like that, but actually inside of the tool that help contextualize. And I go every day. So it is a great, great resource. So help thinking about what does data quality look like when you're thinking about Medicaid and CHIP. Okay, so speaking specifically about race and ethnicity and TAF data. So I want to start by showing this map. This is one of our DQ Atlas maps. This is for 2020. So you can look at this map and see from the range of colors that there's just significant variation in the quality of reporting of race and ethnicity data and TAF across states. So some states report high quality information and some states report much lower quality information. The way that we assess quality for this is both missingness and accuracy. So if there's a lot of missing data, you would have a higher level of data quality concern, but you might have complete data, but we have some states, for example, where a state might say, I'm 100% complete, but I've reported that there are no Hispanics in my state. Well, that's probably incorrect, right? So just because you're complete doesn't mean you're usable. So this is an example where we want to look at both factors before we determine if we can use the state's data. And that's what we do in this DQ Atlas measure. So we're looking at reasonableness by comparing to the American Community Survey and also completeness. I would say broadly, if a state is green, you could use their data. When we get into the other colors, I think it would depend on the group that you're interested in and what the nature of your project, is. Another thing I want to highlight too, because we see this in Medicaid a lot, is people will say, well, I'll just use all of the green states. Well, racial and ethnic groups are not randomly distributed. And so if you do that, for example, if you say, I'm just going to use the green states, well, then you're not using Texas, you're not using Florida. It might be difficult to tell a story about Hispanics, for example. So just keeping that in mind, that is a common approach, not necessarily criticizing that approach, but if you're trying to tell a more broad national story, you have to be very careful about what the subset of states that you're left with is. Okay, so why is that? So we get a lot of questions about, well, why is there so much variation in state reporting? We do a lot of technical assistance with states to work on data quality across a variety of topics. Why can't states just submit better data? And that is a totally valid question, but there are a number of barriers that states face in submitting higher quality and more complete information. And the number one is that most states are getting this information from an eligibility application. This element is not required in making an eligibility determination, which means that you cannot force a person to answer this question in order to become eligible for Medicaid and CHIP. So a lot of people will choose not to answer, right? So a state can't force someone to answer, which means that if someone doesn't respond and doesn't answer it, there's no way that they can get it and send it to us. And that is really one of the number one issues. And then when the data is collected, there might be a lot of factors that impact a state's ability to report it. That could mean in their own MMIS. Maybe that state MMIS system doesn't have the capacity to hold two options and it'll only take one. So there's issue in reporting multiracial. It could be in mapping those categories back to the ones that CMS has asked for. They might be something in the transformation of the data that creates an issue when they send it back to us. So there are multiple layers. It could be at the collection level with the potential applicant or enrollee. It could be in the state system level. It could be something in the transmission to the federal level. So a lot of places where this could break down. And this is one of our TMSIS OBAs, that's outcome-based assessments, meaning it's one of our priority data quality issues to work with states that, they should be reporting something, all groups should have something represented. But with that said, we recognize that there's a ceiling. Even if a state's doing it perfectly, there's potentially a ceiling at how much data a state could send to us. So while we continue to work on data quality with states, we also want to create analytic solutions that help us look at disparities in Medicaid and CHIP. Mentioning, my story about 10 years ago, people want to be able to do this. How can we make that happen while we're waiting for states to make sure that they get high quality information to us? So this just explains a little bit about how this information is reported. These are more like technical things. This is all in our technical documentation in DQ Atlas. So if you go look at that race ethnicity measure or our resources, this is all there. But this just explains that in TMSIS, they're submitting all these different record segments. And then when we make TAF, we're basically taking those record segments and creating some condensed versions of these variables. So if you have access to our data, you can see, which variables you would have access to, how we're creating them, how they're rolling up basically, and how they're coming from states. For imputation purposes, we are focusing on the condensed measure because that's currently the only level that we're able to impute at. But you can definitely get access to all of this information on our publicly available resources. Okay, so with all of that context, what do we actually do to create the imputations for Medicaid and CHIP? Well, we use the method that you've heard a lot about, the Bayesian improved surname geocoding. So we basically started with this method because it's very well validated and very well tested. It creates this predicted probability for each of the categories using the surname lists and the tract level tabulations from the 5-year American Community Survey. So we're basically using geocoding and those surname lists. That's the core of the BISG method. But we actually have a lot of additional data elements in Medicaid and CHIP that are not always available in other programs. So what we wanted to do was see if we could use some of our other variables to actually improve the accuracy of the model. So one of the other things that we did is we used publicly available publications with methods on how to incorporate first name geocoding. So we created some first name lists based on those methods. So we incorporated that in the model, and that improved both the model performance and the performance of the individual groups that we were imputing. And then we also collect an American Indian Alaskan Native certification variable. So that's a variable unique to our program. So as you saw in the previous presentation, imputations for the American Indian Alaskan Native group can be particularly difficult. So this is actually a variable that when states report it, does actually drastically improve the accuracy of that group in our model. So that's another variable that as we continue to work with states on reporting that variable, we hope to see the accuracy of that group also increase. And then we calibrate the estimates to match the distribution from the ACS. So we basically have those three enhancements: first names, that American Indian Alaskan Native certification variable, and then the calibration of the estimates. So using those, we got the best model performance for creating the imputations. But I think we have this really unique thing also in Medicaid, which is that we have millions of self-reported observations. And so what we never want to do is create an algorithm that writes over what someone has actually reported to you. So we have a really unique ability to combine high quality self-reported information with imputation. So when you get access to these files, when they eventually become publicly available, you'll have everything: self-reported, imputations, and you could use them however best fits your project. But we recommend a hybrid approach where in states that have high quality data, so if you are North Carolina or you're Delaware and you're almost 100% reporting and everything is accurate, we want you to use what beneficiaries have said, what enrollees have said, use what they have told you. But when that information is not usable, giving the example of maybe a state has said, there's no one in this group in my whole state, right? So it's not usable. Or when it's missing, then use the imputations. So we call that the hybrid approach. It's a combination of self-reported information when high quality and imputations only when missing or poor quality. And so in that case, we're also, I think, introducing less error because we're also a much smaller subset of observations would actually be using the imputations. Okay, and so the coolest thing is it's really fun to talk about methods, but it's best to see what does this mean? And so I think the most exciting thing is in Medicaid, even though we've been putting out data for a number of years from TAMSIS now, we've never been able to actually release just a national picture of what does our program look like disparities wise. Like let's talk about some of these key topics and talk about what do we actually see in this program? What's our distribution? How many beneficiaries? And so I think the most exciting thing of this is that we've actually been able to create data products that start to explain what the program looks like. And so I'll highlight a few of them. So these are all publicly available. They were released. There are a number of slides in here. So I just picked of the ones that we released, like 1 or 2 slides to highlight. So the first one, which is just this national picture of what does this distribution look like for race ethnicity and how does it compare? And what we see is that Medicaid and CHIP is more diverse than the overall US population. And I think that seems very intuitive, but it is just so nice to actually be able to put numbers and percentages behind that to actually demonstrate what it looks like. So that's just the first slide. The second slide, which I think is very interesting, is when you break that out, for example, by adult versus children. So we know that the total population is more diverse, but that is particularly true for children. So children are especially diverse, and especially in the Hispanic enrollee category. So we have a really, really large number of Hispanic children enrolled in the program. So I think that's a really interesting finding. Going back to that, when you start to actually view this data through different lenses, you can see some really interesting stories, and then highlighting there's so much variation, right? That like, if we go from overall and then we start breaking down into age groups, even what we'll see there is different. And then this is at the end of these briefs, each of the briefs that we release, there are these data tables. And so I also love this because we'll often get questions where if there's a speech or there's a presentation, we would like to say, you know, how many people, I'm giving a presentation to this group, how many people from this group are enrolled in this program? And what's great is you could actually go to this table and you could look, and it might be right there for you. So if you want to cite a number, it's basically like you have the actual, this underlying data table that helps put some of those numbers and that context into whatever you're talking about when you're talking about Medicaid and CHIP. Okay, so this is one where we looked at the brief on geography. So we look at rural urban. This is an access issue that we're always looking at for Medicaid and CHIP. And this, in the results here, we would see, for example, that the rural population is predominantly white compared to the other urban categories, and the urban categories have a larger Hispanic and Black population. So kind of getting into that geographic breakdown and being able to put some numbers behind those distributions. For this one, we looked at disability related eligibility categories. You can see, for example, that the disability category has a larger white category and a larger Black category, for example. So once again, just getting into these data tables, you can go look at these charts, and then you can actually look at the underlying data table at the end of the presentation. And then the last one was on primary language. So we are able to assess English, Spanish, and other. And we also have a DQ Atlas topic, or are releasing a DQ Atlas topic on this topic. And so I will highlight for this one, if you look at this brief, just please read the footnotes, because there are a number of states that don't have usable information for this. And getting back to that distribution, many of those states are in the Southwest, for example. So that could potentially skew the results. So definitely reading the footnotes for this brief is particularly important. But you can see just the language diversity and how that overlaps with race and ethnicity. So I just really wanted to highlight that we love getting questions from our data users. We want to build products that meet your needs. Please reach out to our help desk or me, and I can help connect you with the right people if you have any questions. And our goal is just to keep releasing information where we can view key Medicaid and CHIP topics through an equity lens, hopefully moving into utilization, services, outcomes, things like that. So we're really excited about what the future holds data-wise, and we really hope that many of you become data users. Thank you so much.
Hi, my name is Clara. I'm from Massachusetts and Mass Health, Mass Medicaid. We're really excited about this because we've been working through how best we can. We are one of those states, unfortunately, that is in the red on that map, or at least dark orange. And so we're excited to make sure that we can begin to act on our inequities that we know exist without our perfect data, although we're also working on improving that. Did you mention that we would be able to access the imputed data that you've developed for each member, and for example, use it as a state level to better understand inequities that you may not have analyzed or otherwise looked at? Or is it intended to be used at a national level?
I'm pretty loud, but I'll talk into this anyway. So yes, what I would say is reach out to the help desk. So right now, for external actors, the CCW is the primary way that data is accessed, and that's via ResDAC. But we are, one of our main goals is to work with states and to help them use their data efficiently. So what I would definitely say is reach out to the help desk, and whether that's putting you in contact with ResDAC or working with you directly to think through what options we have, like we definitely can move forward with helping you on that one.
Hi, Cameron Adams, Access Arizona Medicaid. Thank you for all of this. Really look forward to reading the report yesterday, and really all of your work this past decade on it. I have a half a dozen questions, but I'll stick to one or two if they let me here. So you had mentioned that this is really applicable at the population health level. Has there been any effort to validate at the individual level?
So that's a great question. And so there are some limitations in our ability to how we can validate the data. So unlike Medicare, we don't have any surveys that we can use as external benchmarks. So the way that we've currently validated the method is to basically take states that have high quality information and check the imputation against those high quality states. That's obviously a limitation because in poorer performing states, there's really no way to actually check what the accuracy of the imputations is. But we are currently working on what options we would have to potentially link to other data sets that might have individual level information to check. So it's 100% something that is on our mind of how to assess and then share. So we'll be able to share, like in our user materials, the assessment that we've done. So you could actually see what it looks like at a group level, but 100% moving forward, validating it at the individual level through linked data is our goal.
Thank you. Okay, there are other questions, so I'll pass it. I don't know.
Oh, mine's quick. Hi, Christine Nixon with A1M Solutions. I just had a quick question. It looks like the data on the charts was through 2020. Does it take 3 years to refresh or?
Yeah, no, that's a great question. So, and I am sorry that I might talk about how the data is created very technically, but this is also available on our documentations online. So basically what happens is state data comes in. Enrollment data is basically accurate the month it is submitted to CMS. So let's say April data states would submit by the end of May, and then we would ingest it and create a file for internal analysis by the end of June. So that's like that's called interim TAF. You can read about that in our materials. So enrollment data comes pretty quickly, but claims can take a really long time. So like, let's say an inpatient managed care claim, like a delivery is a common thing that's covered via managed care in an inpatient setting, that could take 9 months to come. So part of the reason that it takes a while for CMS to release claims is we have to have like a preponderance of the claims in our system before we can share it, or else you analytically could not use it in a meaningful way. So what is normally done is when OEDA releases RIFs, they release what's called a preliminary RIF, where every month has at least 6 months of submissions. And then a final RIF where every month has at least 12 months of submissions. So basically saying 6 months, we have 95% of everything, 12 months, we have everything. So then what we have to do is we actually have to geocode all those beneficiary addresses, highlighting that in 1 month, it was 93 million. Over the course of the year, it's well over 100 million. So it's it's just a lot of technical resources to geocode that many addresses. So we wait until we have that at least preliminary file to run the geocode. So that's why you would basically need at the end of a calendar year, 6 months from December before you could run the geocodes. So we have to wait for that piece because of that time lag. And then we can run the imputations fairly quickly after that. It doesn't take, we're talking in the span of a few months after getting the geocodes, but the geocodes can also take a little bit of time to get as well. And then we have to package that and then release it via the standard CMS data release process. So it doesn't take 3 years. The first year, like we're working on 2021. And so we're optimistic that we'd be able to deliver those, much sooner than we were able to deliver 2020. So I think as we stand this process up and it becomes more routine, it will be faster, but it will never be like a right away process because of that time lag.
All right, me again.
Yeah.
Any insights on the new OMB categories that are going to be released? Is it going to be in a condensed format? Can you tell us that?
I do not have any insights into that. I'm sorry. So I think OMB would best be able to answer that, and OMH is actually a great resource on those too, just that CMS tends to reflect the OMB standards. So if there are changes, we would expect those to be reflected on whatever the OMB timeline is.
I knew it was a Hail Mary, but thought it was.
Oh,
worth
yeah,
asking.
yeah.
Hi, Rachel Harrington and CQA. I actually want to build on that, but in a slightly different direction around disaggregated categories. So one of the things we know OMB is working on, but it's been in the OMB 5 and 2 is breaking out Asian and Native Hawaiian, other Pacific Islander, some of the other disaggregations there. And we know that the current prediction algorithms don't perform very well when you start getting into subcategories like that. So I'm curious in either of the work streams or in Medicaid where you have some of those more broken out categories, if you're taking a look at ways to improve the algorithms or just any thoughts that you might have there on how we can get to more disaggregated data.
Yeah, that's a great question. And it's one that we get a lot. And so the first thing I would say is that I definitely think it would be very interesting to conduct a data quality assessment in some states where we know there is a large enough population, for example, to disaggregate. So I think that's one of the considerations is that, especially in Medicaid, when we're looking at all states, state populations can look really different. So I think focusing assessments on states that have like I'm thinking California, states with really large populations where you might have a large enough sample to actually assess. So I definitely think from a data quality standpoint, you could probably do some type of assessment of the Hispanic and Asian categories rolled out. The other thing, and we have not explored this, so it's more of just something that I'm interested in and would also be curious about, is the way that these surname and first name lists are created, the possibility of if that could be used in any capacity and in any of these disaggregated groups. And I don't have a good answer to that other than that, it's something that could be explored to see if it's possible. I don't know if you have anything you want to add.
So on the Medicare side, it's a little bit challenging. As you can see from Nancy's presentation, we received the data from SSA, right? So unless SSA is able to collect the data at the disaggregate level, which at this point, we're hoping for what we call the 2011 HHS data standards. And that's broken down the Asian category by 7 categories and the Native Hawaiian by 5, I believe. But until they're able to give us that source data, it's harder for us to impute the data. However, knowing the issues, we are exploring different types of options in terms of how we can do that with census data. So hopefully more to come in the near future. But as you can see, it took almost 10 years for Medicaid. So crossing our fingers.
I commend the work that you guys have been doing. I have a question around how the algorithms might be checked for bias. So how are you making sure that the algorithms might not be perpetuating biases as they're predicting race and ethnicity for individuals or categories?
So I just want to say, I think this is a great question, and it's one we get a lot of very often, which is just, is this ethical, and are the results that we're creating ethical? So I just want to say we have kept that framework, I think, the whole time that we've analyzed this. And one of the slides I've shown in another presentation is it's results from the COVID-19 public health emergency, and it shows people reporting results. I think everyone probably knows that there were substantial disparities in terms of the effects of COVID. And when people use data that was not supplemented with missing data, it actually drastically underreported the burden of COVID-19 on the Black and American Indian and Alaska Native populations. So I think what I would say is 100% being worried about the ethics and checking them. I think mentioning these accuracy analyses, trying to get to this individual level enrollment, what I mentioned about states, which is just doing a lot of work to make sure people can tell you who they are versus guessing. I think all of those things are essential. And then the only, I think, context I'd provide around that is that, we should be worried about using the source data, I think, also, because we definitely can create the incorrect conclusions when we're also using data that might have inaccurate or missing data that also creates bias. So I think we're in a tough data situation where it's never perfectly accurate, whether we're using source data or imputations. I think the benefit of imputations is that we can be transparent about the method, and we can do our best to just acknowledge when it's wrong. And especially, I think, in both categories, I would freely say, I think that the imputations are very imperfect for American Indian, Alaska Native. And I think we would really want to contextualize any results we had with either data source probably that we're underestimating the significance of the burden on that community. So yeah, just it's a guiding principle for us. I think there is research that would suggest that we might, using the imputations, hopefully should actually lessen some of the bias that we would see and help us accurately count. But that a lot of our work goes into not just making the method better, but just making sure we can actually get data from the enrollees themselves. Yeah.
And only thing I would add to that with Medicare is, again, being able to utilize the self-reported survey data that we have from the Medicare Current Beneficiary Survey to check and where adjustments are needed. So the RAND team has been very helpful with constantly assessing the imputation to see if there are any updates that can be made, what biases exist, but it is an imperfect method. So as Megan noted, really primarily what we want is better data directly from enrollees. So that's the goal. And in the meantime, we do take very seriously limitations of imputation and make sure that where we can assess and modify to improve, we do so.
And we're also going to take a few questions from the virtual session. So one person asked, can you elaborate on the MBISG as a categorical variable? The literature indicates MBISG users cannot simply select highest probability and impute as the beneficiary's race.
Yes, so that is not recommended because, as was noted, the probabilities reflect so across all of the racial and category groups, accounting for some inaccuracy. So selecting the highest category introduces more bias. If there's instances where you feel or you are curious about if that would be appropriate for your particular research purpose, then I would recommend reaching out to the support box and we can discuss the methodologies and see if that would be appropriate again for that intended use, but largely we caution against using it categorically.
Thank you. And then one more, which states have the high value data? Is there a ranking somewhere?
Yeah, so it's just a data quality assessment. And so if you go to the Medicaid DQ Atlas, you just Google it, or there's a link in this presentation that will show you that state map. And it'll show you where it'll give you data tables and the methodology document. It's not a ranking because, as I mentioned, it's really there are many instances in which it would really not be a state's fault at all if they submitted data with a lot of missingness. But it's basically just an assessment of a level of concern. So low concern means it's reported inaccurate, and high concern or unusable. Unusable might mean there's not anything reported there, for example. So Medicaid DQ Atlas, and it just shows you that range of data quality concern.
Thank you.
Hi, Ali Liss with DC Medicaid. I was curious if there are any particularities when looking at this data with the duals population, just sort of knowing the overlap between sort of how data is collected on them and then being able to get sort of a comprehensive picture.
Yeah, that's a really interesting question. And I would definitely say, so those data briefs that we published, we do have some information broken down by eligibility category in the data tables and by age. And I thought it was so interesting because there's a lot of variation. Like, for example, there was significant other language diversity in the duals population. So based on the racial distribution, probably a large number of Asian language speakers, for example, disproportionately relative to the other distribution. So we do have that in those briefs. And we have not assessed data quality wise separately for duals versus the broader population, but we are trying to look at the variables that we're releasing, the other equity variables, and whenever we can, eligibility service use by the dual category or by age-related categories.
Hi, I'm Martha Kemp from SAMHSA, and I have heard from the field that there have been challenges where some states create higher barriers for accessing Medicaid and Medicare, or CHIP, I should say, not Medicare. But I'm wondering if there is any data collected from the state on incomplete or denied applications that could highlight those types of challenges.
Yeah, sure. So I will say that in the TMSIS data set itself, we do not collect that type of information. So at least in our data set, we don't have anything on eligibility barriers. It would just be who is actually enrolled and the services related to them. But if you do have questions about, there are a variety of other Medicaid data sources. If you email our help desk, we can try to triangulate across the center to see if there is a resource that we can put you in touch with.
Thank you. That's a great presentation. Jenna Stern with Vizient. Just a quick question. You had mentioned potentially looking into broadening the scope of data available and looking at like utilization data. I'm curious if you could just speak to kind of where you are in that process or potential barriers or opportunities.
Yeah, sure. So we do release a number of data products already on our TMSIS analytics page that look at a variety of key Medicaid and CHIP topics like substance use disorder, pregnancy, a variety of utilization measures. The difference is now that we want to add that equity lens. So if you go onto our website, you can find all these data tables by state and a variety of other data filters already publicly available. But so it's basically taking those reports that we've built where we have those 4 stratifiers and starting to apply them to the topics that we're also already releasing data on. So basically that's what we're working on, making sure that we're covering the right topics. So once again, kind of with our help desk, if there are things you were really interested in seeing, if you go to our analytics page and you're like, I love this pregnancy stuff, I want to see it through these other equity lenses, that helps us guide the future direction of the work that we're doing. So basically it's taking a lot of the key utilization things that we regularly talk about as a center and trying to share data in the way that we're sharing in these briefs, where you can start to see services for kids. If anyone has looked at our data briefs throughout the public health emergency, we published lots on kids utilization during the pandemic, for example. So basically tying a lot of those topics that we're already releasing a lot of data on, and then trying to apply these race, ethnicity, language, geography, disability lenses to them. And hopefully over the course of the next year, we will continue to release the types of briefs that we released yesterday.
Me again, third time. I'll make this a dual part question because I just like to make things challenging.
Okay, all right.
So understanding that the TMSIS files, the raw files that come from Medicaid, are at the individual level, does CMS anticipate requiring the source of the race, ethnicity, other factors to come across on the TMSIS files in case we start using imputation? Given,
so that one was, do you think we'll require the source to use imputation?
Yes, on the TMSIS file.
And I would say, as of right now, that would be no. So whenever there's a TMSIS change, the TMSIS team would institute that change and then do a lot of technical assistance with states, and that would be on a long time frame. But just this is my experience being in Medicaid. It's very difficult for states to implement these types of complex methodologies on the front end and send it to us. So it tends to be more transparent to the user when we apply a single method. So if we said states go impute, what you would end up with is 50 different imputation methods. And so it tends to be a little bit more efficient to say, send us what you have, and then we can apply a single method where at least it's transparent to a user exactly what's happened. The other thing is, because almost all the TMSIS data from a state comes from a downstream eligibility system, it would really have to happen at that eligibility system level. And I think that would be complicated probably for a variety of system and analytic reasons. So I think that would be a difficult process. That doesn't mean it would never happen, but as of right now, there are not plans to implement a change like that.
Well, now I have a new question.
Okay.
So, then do you encourage states to impute data?
We haven't issued any guidance about imputation to states in any format. It is just an analytic tool that we are applying to make the data more useful for ourselves and for users. We do give lots of guidance to states. So we talk to states about their race, ethnicity data. We've given a presentation on some of the states that are green. We actually had a conversation where we said, we understand why this is really hard, but why is this easy for some states? Like, why are some states doing so well? We were almost, curious. So we did some case studies, and we have those states present at all state calls. So we definitely try to share information like best practices, what we're finding. Hopefully we'll be able to, present these results to states and work with them. So I think we're happy to work with states on their Medicaid analytics to any capacity we can. But there's not currently any guidance that states should do this or requirement that they should do it.
Okay, thank you. I do have another question, but I'll scan in the room real quick.
We're doing back and forth on questions. I wondered if you could speak a little bit more about how you're thinking about data quality. You mentioned completeness and accuracy and how important both of those are in thinking about the quality of the data. And sort of, are there any creative ways the field can kind of help move that idea of quality of race and ethnicity data forward? Are there linking opportunities from some like the CAPS or MCBS or other survey data, or some of the, like the AIN, the certification? Like, what is your thinking on how we continue to kind of keep an eye on data quality in this space?
Yeah, I think the number one thing I'd say is use the data, use it, publish it, share it. Like, that is where so many of the questions and assessments and solutions come from. Because, TMSIS, I always feel silly to say it's a new data set, because, it is multiple years going now, but given the release schedule and some of the enhancements and the data quality work, it still feels new in a lot of ways. And so what I would just say is, get in there and start using the data and publishing it, and start using the imputations and using the equity topics. And I think that as like the literature on this continues to grow, it helps us identify the gaps. And it also gives us good benchmarks and results to help contextualize the analyses that we're doing. So I think part of it would just be, if you're using the data, communicate what you see so that we can take that back to the state technical teams working with states, or take it to our analytics team to build potential solutions. Or, use it, publish it, and share it with us so that we can help create this large body of evidence. But the best feedback we get is from regular users of the data who just know what they see and have questions and want us to help them work on things.
Your question over there?
Last question. Could you talk a little bit about how multiracial was predicted through the algorithms?
Yeah, this is a great question, because I think you've gotten, I can't speak for your algorithm, but it's one that there's a significant issue with. So you will see if you read our materials and when our user guide goes out, that we basically would recommend not using the multiracial category, even from the imputations, because we get so few observations that actually come through as multiracial in the source data. And then there's so much difficulty in using the probabilities to actually create a multiracial category, that basically what we would say is, from a technical assistance standpoint, we would really need to work with states to get a much larger sample of multiracial responses before it becomes very useful. So I think that is a major limitation. And I'm so glad you asked that. It is really not analytically meaningful in our imputation algorithm at this time. Absolutely.
The only thing that I will add to that is that I think, which Kim, you alluded to as well, as we get to further advancement in the standards, where we have more disaggregated options and more reporting, self-reported of multiracial, then I think we can see that improvement in the imputation methods. But again, the low reporting is a clear indication that this is not currently hitting the mark.
And I want to say, during the comment period for the OMB, whatever the new standards may be, there has been a lot of discussions about that, as well as and how the different types of breakout, to capture it. And especially for the Medicare side, or some of the enrollment form that are paper-based, right? Imagine when we expand it to the disaggregated level, including the multiracial, like how many categories is enough before somebody decided not to provide the information, and we need the information. But thank you so much for joining us this morning. All great questions. I hope you got Kim's email address before that slide disappeared. But we're all in the speaker list, so you can just Google us from the CMS website, and you'll see our names, welcome, any questions. Like Kim says, your questions help us improve our data. So it's very important that we get that feedback, and enjoy the rest of the conference. Thank you.